Sangeetha is associated with Pallium in India for the last 2 years. She is the senior palliative care physician and pediatric palliative care in charge of Pallium India Trivandrum. She has completed her MBBS from Sri Kokulam Medical College Trivandrum, and her areas of interest are community home-based care and pediatric palliative care. Welcome, Dr. Sangeetha. Welcome to the session, and over to you, ma'am.
Thank you, Sinia. A very warm good afternoon to everyone. I know this is a post-lunch session, but I'll make sure to make this more interesting to you. Okay, so I hope this is a batch of nurses, and this is your first session on gastrointestinal symptoms. So today,
just a minute, ma'am. I will share the PPT.
yeah, today we are going to discuss the common GI symptoms. GIT will be taken in two parts. In first part, we'll be dealing with nausea, vomiting, constipation, and in the second part,
excuse me, ma'am. Can you please remove your mask and speak?
Okay. Yeah. Okay. So in the first part, we'll be discussing regarding nausea, vomiting, and constipation. And in the second part, we'll be dealing with intestinal obstruction and the symptoms associated with that. So I know most of you are working in hospital-based setting, and you might have come across so many patients with nausea, vomiting, and constipation. So before we get into this topic, I would like to start with a scenario. Here, I have brought in a case where a 55-year-old female lady, she is diagnosed to have gastric carcinoma, and she is on chemotherapy and was admitted in general ward for the treatment of urinary tract infection. And she was admitted with complaints of vomiting, abdominal colic, and fever. Now she is tired and has, and she is on her antibiotic course. She has small, frequent, incomplete bowel movements since 4 days and started today on laxatives. She is accompanied by her younger daughter. So this is a typical scenario. I have put in this case just to understand more regarding today's topic. So I hope this is clear to you. Anyhow, here what we are going to discuss is to address her main concern and how are we planning to investigate on this and what is the management that we can do. Okay, so keep this case in your mind. After a short while, we'll come back to this. Okay, so we'll go ahead. So what is vomiting or what is emesis? Vomiting means it is a defense mechanism, biological defense mechanism, wherein the body itself tries to remove the toxic or harmful substances from the body after it is ingested. Actually, it is a process. This process can be explained in 3 phases. So normally, the body is trying to throw that thing away, or something that is that which is not good for you. Is the body is trying to get rid of it. Okay, so that is the process which we call it as vomiting. So it can be divided into, it has 3 phases. First is nausea, that tendency. The patient feels like nauseating, but he hasn't vomited yet. The second phase is vomiting. And the second phase is retching. Retching, where the body has having some muscular movements whereby is that the diaphragm is pushed to throw out the gastric contents. And the third phase is vomiting, where the gastric contents is thrown out. Okay, so nausea, it is an unpleasant sensation of the imminent need to vomit. It is just a sensation, nothing is going out. Now, vomiting means there is forceful expulsion. The gastric content is going out. Okay, here again, what happens is it is associated with contraction of the abdominal and chest wall musculature. In retching, what happens is there is spasmodic respiratory movements against a closed glottis, and due to this contraction, there is without the expulsion of any gastric content, there is just the process is happening. In vomiting, the muscles contract and the gastric contents goes out. In retching, the muscle contracts, but there is no gastric content going out. Okay. So, can some of you tell me what are the different types of vomiting that you see, or that you know of, the types of vomiting?
Projectile vomiting.
Okay. What else? If there is projectile, then what is the other thing? Please don't be shy. This is an interactive session. You can learn from each other. There is nothing to be afraid here. We all have done some of the other mistakes. This is how we learn. Is there something called as acute? Have you heard of it? Huh? Hematemesis, okay. Okay. So the types of vomiting, you have acute type of vomiting, delayed type of vomiting, breakthrough vomiting, refractory vomiting, or anticipatory vomiting. So in acute vomiting, what it means is it occurs within few minutes to hours and it resolves within 24 hours. That means it is in a short span of time the person is vomiting. Okay, here mostly the type of vomiting that we are going to discuss today is chemotherapy associated vomiting. Okay, that is a common thing which we are seeing on a day-to-day basis. In delayed vomiting, what happens is usually it is after 24 hours of chemotherapy, the patient starts vomiting and it can last up to 48 to 72 hours, mostly following chemotherapy. Yeah, even it can go up to 7 days. Okay, that is delayed vomiting. At the time when the person is taking chemotherapy, he may not have any symptoms, but after some times, maybe after 48 hours, he will start vomiting. Okay, now breakthrough vomiting is you have seen this person and we have started him on some antiemetics and he was doing well. But in between, he's having still some vomiting episodes. So that is in between the intervals of this antiemetic, there is some breakthrough vomiting happening. Now, what is refractory vomiting? Refractory vomiting means there is, irrespective of what all antiemetics that you are giving, there is no relief at all. You are trying ondansetron, you're trying metoclopramide, you're giving haloperidol, you're giving benzodiazepine, still there is no kind of relief. Then we say this condition as refractory vomiting. Now, what is anticipatory vomiting? Anticipatory vomiting means the person is going to have his chemo on the next day. On the previous day itself, he'll have that thought in his mind, oh my God, I'm going to take chemo. Soon after that, I will have this vomiting episodes. I know my body is going to have a lot of pain after taking this. Such kind of thoughts itself produces that vomiting sensation. Okay, so he's anticipating that he might vomit and eventually leading him to having nausea and vomiting. So today we have discussed regarding acute, delayed, breakthrough vomiting, refractory vomiting, and anticipatory vomiting. Okay, so you must know all these types and what are the factors which is leading to all this. So today we are having an entire session on nausea and vomiting. Why is it important to have an entire session on this? What is the importance, or why are we concerned with nausea and vomiting?
Because after the chemo, all get this.
After the chemo, I didn't understand you, sister.
After the chemo, most of all the patients get this vomiting.
Yeah. Why is it important to treat vomiting? Why are we
Because of-
concerned?
If there is vomiting, the patient cannot have intake or retain anything.
Yeah. Yes. The patient will not be able to take his food. Second, his medications, even his family will be upset. See, my father is continuously vomiting, then how will I have my feed, or how will I take food? It is quite distressing for the patient as well as the family. Okay, the patient will be in some pain medications as well, but he is not even able to take that pain medicines because he is continuously vomiting even that medicines too. So it is important because it affects the patient's daily functioning. His quality of life is impaired there. There is no compliance to the treatment. He may be on some chemotherapeutic drugs, or maybe he's on pain medications. He's not able to take even that. So it is difficult for him. There is inadequate symptom control, the fear of anxiety, poor absorption of medicines. All this can happen because of this vomiting. And it escalates the distress, both for the patient as well as the family. Okay. Even though we can say, we may feel that nausea and vomiting is simple, it is easy to treat, but sometimes it is very difficult when it comes to cancer patients. So it is very important that on the initial stages itself, make sure you're treating this nausea and vomiting. Now, what do you think is a cause for vomiting? Treatment, medicines. Okay. What medicines causes vomiting? Chemotherapy. Yes. Opioids. Yes. Very good. Antibiotics. Yes. Indigestion radiotherapy. Okay. So there are different causes for vomiting. Okay. And for different causes, the antiemetic that you choose is also different. So it is not possible to give ondansetron for everything. There are cases or there are situations where particular antiemetic should be given in particular condition, and some antiemetic should not be given in the condition. So it is important to know what is the cause and then only give your antiemetic. Okay. So there are different causes and different types that causes the vomiting. It can be chemically induced nausea, especially in case of opioids, as some of you mentioned. Some antibiotics or cytotoxins can cause this nausea and vomiting. Even food poisoning, ischemic bowel disease, or gut obstruction, metabolic organ failure, all these things can cause nausea and vomiting. Now, gastric stasis, anticholinergic drugs, opioids, ascites, peptic ulcer, or gastritis. This gastritis can be stress-induced or drug-induced. Okay. Now, stretch or distortion of the GI tract, especially if the patient is constipated, intestinal obstruction, mesenteric mets. These are very common that you see on a day-to-day basis, especially if the patient, very common symptom, constipation. Most of the palliative care patients who come to you might be constipated on the first sitting itself when you see them. They might think it as a very common symptom. It may not be causing any problem for them, but make sure you are asking that patient regarding their bowel patterns. Okay. Ask them if they're having any type of difficulty in passing stools, or if the motion that which is being passed, is it blood stained or not, or any color change. Ask in detail regarding that, because it gives you a lot of hint regarding what is the present condition of that patient. Okay. Mesenteric mets, again, there can be multiple mets, and these mets can cause stretching of the GI tract. This stretch or the pressure receptors get triggered, and which in turn leads to nausea and vomiting. Okay, now serosal irritation, example liver mets or uterine obstruction. Liver mets is very important, because in most of the conditions you can see the report coming as associated with some liver mets. So definitely when the liver mets happen, the liver capsule get enlarged, and again, here again the pressure receptors get stimulated, and which in turn leads to nausea and vomiting. Okay, now irritation of GI tract. Is there any infection that, or is there any intake of specific NSAIDs, drugs which is causing this nausea and vomiting? Always ask for that history. Raised intracranial pressure. As everybody knows, in the space occupying lesions or in any intracranial bleed or infection, which in turn can lead to nausea and vomiting. Any movement associated, especially if you might have traveled to any hilly area, or maybe if the patient is changing positions, benign paroxysmal positional vertigo, even some vestibular disorders can lead to nausea and vomiting. So this is one thing which you should definitely ask for. Then, is it associated with any anxiety? Some people, they might have that fear in them, especially if some kids before going for the exam will have some kind of these symptoms. They'll develop sudden nausea and vomiting, or maybe they present to you with diarrhea. These are anxiety-induced stress factors leading to nausea and vomiting. Okay, then again, we have environmental factors, like for the smell of certain food, or some cleanliness issues, or some distaste to particular things. All this can induce nausea and vomiting. These are very commonly seen in our day-to-day setting. So make sure you identify the particular cause and correct that particular thing. Okay, you can't see it. The person is having some decubitus ulcer, and it is very foul smelling. Okay, and the patient is continuously vomiting. Definitely, if you are also in the similar situation, because of this foul smell, you may not be able to take any food. You may also have the symptom of vomiting. So here again, the cause is that wound. Okay, so treat the wound first, and definitely along with that, his vomiting will come down. Or maybe if the patient is having some colostomy, and continuously the fecal matter is being drained. So environmental factors will also play a major role. So make sure you identify the cause. According to the cause, the treatment also will change. Okay, that is why we have to give prime importance for the in identifying the cause for nausea and vomiting. Now, is that all? No, there are other factors also which can cause nausea and vomiting. Okay, what is oral thrush? Once a patient is, you're seeing the patient and he's continuously vomiting, make sure you are seeing his oral cavity also, because you can see the candidiasis, oral candidiasis happening there. And what is the treatment for oral thrush? Can anybody say? Because you are the people definitely giving oral care for them.
Proper cleaning.
Cleaning with what, sister?
Maybe betadine also. Betadine solution.
Soda bicarbonate, okay.
Chlorhexidone.
Chlorhexidone, okay. Salt water gargling. Okay.
Tablet fluconazole.
Fluconazole. Okay. Candid mouth pain. Okay. So here, what I'll tell you our practice, and it has been very effective for them. If it is severe oral candidiasis, we would give them a course of fluconazole tablet. Along with that, we do the oral care. How we give the oral care is in a glass of lukewarm water, we add a pinch of soda bicarbonate, a pinch of soda bicarbonate powder, and little bit of salt. And we mix it, and with the oral swab, there is a small sponge like thing available with a stick. We dip it in this water and clean the tongue, the surface of the tongue, and all over the oral cavity. If the patient is able to gargle and spit it out, well and good. Okay, even if this fluid just goes inside, it's okay. But make sure the amount of soda bicarbonate that you're taking is just a pinch. Okay. In home care setting, if you don't have that sponge and all thing, what we usually say is at the end of the spoon, on the back of the spoon, we tie a small piece of cotton cloth, dip it in this water, and then clean the oral cavity. Make sure the caregiver is using the spoon. Otherwise, if the patient or the caregiver is using their fingers to do this thing, what happens is the patient will automatically unknowingly bite the finger. So we may say them to use the back portion of the spoon, tie a cloth around it, and dip it in this water that is being prepared. Twice or thrice a day, you can just clean the oral cavity with that. The patient is able to gargle with it, definitely you can use. Potassium permanganate, usually we don't use it here. This is the typical preparation, which is cost effective also. The soda bicarbonate powder is definitely available at home as well. So this is very effective. Maybe twice or thrice a day, you can ask the patient to gargle with it. And also you can clean in this particular manner as I said earlier, you can clean the surface. And if the oral thrush is severe, even in the palatal area also, you can see the thrush, then you can start a course of fluconazole, maybe for 5 to 6 days as required. Decaring gel application, now we are not having that practice. I don't know about that also. Okay, we use candid mouth paints. Maybe 6th hourly, we have this practice of using candid mouth pain if it is severe thrush. Okay, and also make sure the other causes are halitosis, mucositis, dysphagia, dyspepsia, hiccups. All these things are also other important causes which you have to keep in mind, which can lead to this GI issues. Okay. Oral thrush is very common. So the oral care, especially users will be doing that. So this is also a technique which is available and which can be done at home very easily. Now, how do you choose your antiemetic? Can some of you tell me what are the different antiemetics that you know? Common antiemetics which is used in your facility.
Ondansetron.
Ondansetron, okay.
Injections of
Perinom, Emicet, okay. Temple, okay. Domperidone, okay. Yes, domperidone. Anything else other than this? Promethazine, okay. Okay, so choosing your antiemetic is very important. First, you have to identify the type of vomiting. Then you have to identify what causes this vomiting. And once you know the answer for these two questions, next thing comes, how do you choose your antiemetic? What should be given in this particular cause and what should not be given? All those things should be kept in mind. Okay, so identify the cause, identify the pathway which triggers the vomiting reflex. In a short while, I'll show you a small video where you'll get more idea how the vomiting happens and all that. Okay, So then the next thing is identify the neurotransmitter receptors involved. Maybe that is not required at your level, but still, if you know it, it is well and good. Okay, choose the potent antagonist at the receptor, identify the route of administration. Here again, the person is continuously vomiting. So there is no point in giving him oral antiemetics. So we'll have to see some other methods. Even you can give sublingual preparations or maybe IV preparations, or subcutaneous preparations are also available. So we'll learn about that in a short while. Now, once you start giving the antiemetic, you have to titrate the dose, monitor the patient, see if it is his vomiting is being corrected, is he doing well, and how frequently you have to give this antiemetic. Now, our objective here is to stop or to reduce the frequency of vomiting, to establish compliance of treatment. If we don't control this vomiting, here again, as I said earlier, these pain medications can't be given, or some other medicines like chemotherapy drugs that can't be given. So definitely we have to take care of nausea and vomiting, and again to administer other oral medicines to improve the quality of life. Now, coming to the principles of management. So correct the cause. There are non-pharmacological measures, which is very important, especially in our setting. Non-pharmacological measures are also very vital. There can be some dietary modifications which can be explained to the patient as well as caregiver. And we will also look into some antiemetics which is going to help the patient. Now coming to non-pharmacological measures. Avoid situations which induces nausea and vomiting. So as I said earlier, if the patient is himself having a very bad foul-smelling wound, or maybe if he is on colostomy, so that things maybe we can't avoid a colostomy, but we will definitely have a solution for that. How to do the bowel care, or do the colostomy care, or do proper wound management. All these things can be done, isn't it? Or maybe the environment where he is something very uncomfortable for him. Such kind of things, if it has a practical solution, identify that and do that for him. A calm, reassuring environment can be provided if possible. And always there should be fresh air coming in. Open the windows, there should be always that fresh air. When the patient feels he is suffocated, again he has a tendency to vomit. Okay, now whenever you're feeding him, make sure he is in the upright position. Only then give him the feeds. And also make sure you're giving the person good oral hygiene. It is of prime importance, especially when the person is vomiting. After each episode of vomiting, a good oral care should be given to the patient. And also there is a practice where I have seen once a patient vomits, that vomiters will be collected in a bucket, and bucket will be near to his bed itself. Again, the smell triggers him to have another episode of vomiting. So make sure his environment is clean, and always fresh air is coming in. Okay, as said earlier, this malodor and decubitus or fungating tumors can be again a triggering factor for this nausea and vomiting. So try to correct it or give proper guidance for its management. Another thing is using suitable distractors. Many of you might have seen, especially when a person is started on chemotherapy or in that chemotherapy ward, what happens is like they'll be given some magazines, or maybe there's some film or some cinema will be there on the TV screens. Why is it given? It is given to distract them. See, taking chemotherapy, definitely the person will be having no sleep on the previous day itself. Or tomorrow I'm going to get chemo, the preparation, everything. He might be very anxious. Okay, so maximum we try to give him comfort during that process. So distractors are very important. There are different techniques which a psychologist uses, something like self-hypnosis, progressive muscle relaxation, biofeedback mechanism, or systemic desensitization. These are all, you can take all the steps if the patient is having severe anticipatory vomiting. The patient is very anxious. We are not able to manage with our medications. In such situations, maybe you will have to take the help of a psychologist as well to control this nausea and vomiting associated with anticipatory vomiting. Okay, so there is, this distractor should be combined with your antiemetic. It's not just antiemetic, this non-pharmacological measure should also be there along with this management techniques. We cannot give one single antiemetic and say it will get, we cannot say that it will be controlled with a single drug. Maybe you will have to use multiple drugs in managing nausea and vomiting. So using this distraction technique, it reduces that feeling of helplessness. You can also enhance the feeling that the patient is having more control over this vomiting. Once the patient gets distracted, automatically he'll have that chance of, the chances of vomiting decreases. Now, what are the dietary modifications that you can say to this patient and caregiver? See, when the patient starts vomiting, the caregiver becomes very anxious. So whenever we treat the patient, make sure you are giving proper guidance to the caregiver as well. What happens is the caregiver, he'll start overfeeding the patient. See, he had a previous episode of vomiting 5 minutes back, so he might be hungry. Now I'll give him more food. You might have seen, isn't it? So make sure they are taking small, frequent, small feeds. Instead of giving one big whole meal, if the breakfast, if he's taking 2 pancakes, make sure you give 1 pancake or half pancake at 8 o'clock and maybe another half, maybe 1 hour after. Like that, small, frequent feeds can be given, not together. All right. So this thing should be said to the caregiver also, because he is the one who is taking care of the patient and he is supposed to be giving the food. So do not insist the patient, especially the patient may be having some, particular smell is triggering him in having this nausea and vomiting. So such kind of things should be avoided and ask the patient what he is willing to take. Okay. So during the daytime, ask him to take the small frequent feeds, and whatever the patient is able to take, only give that much. Don't overfeed. And avoid sweets, spicy and carbonated drinks. Some people have this habit of taking soda water, or maybe any Coke or something like that, because they feel that when they take this, their nausea tendency comes down. But actually what happens is it gives some kind of satisfaction on the initial phase. Later, what happens is they start getting bloated again. So make them understand that this is not going to help you. You may feel a temporary relief initially. Later on, you'll have problems associated with it. Okay. Then you can ask them to give foods that are easily digestible. Something like oats, or maybe something like, well-cooked rice in a pod-rich form. So all these things can be advised. So dietary modifications is also very important, as I said earlier. Now, what else do you have to keep in mind? Always try to keep the mouth clean after each episode of vomiting. Okay, because if you don't keep the mouth clean, again, the person is having the tendency to vomit. Okay, now wear loose fitting clothes. Have fresh air with a fan or an open window. Limit the sound, sight, and the smell that can cause nausea and vomiting. Some particular sound can cause some irritation, and this in turn can lead to some vestibular disturbances also. So make sure he is in a very calm and good environment. And give the contact information of somebody in the team, so that he'll have that reassurance. Okay, if something bad happens, I can call him and there is somebody to help me. This reassurance will also help the patient and the caregiver. Okay, so all these things should also be kept in mind. Now, coming to the pharmacological measures, there are a lot of medicines available for treating nausea and vomiting, but you should know the some important drugs which can be used, because I'm sure most of you are working in hospitals. So your doctors will be writing some or the other thing. Maybe you can also prompt them Definitely, I had so many sisters prompting me, can this be tried instead of this? So you can, knowing this pharmacological measures will help in having that good setting where you can work in harmony. Okay, so make sure you know all these things. It is not of prime importance, but still you will be the one who is administering this drugs. So what is given in what situations you have to be aware of. You don't have to go in great detail, but understand what is the drug and why it is being used and what are the methods by which or up to what dosage this drug can be given. Okay, now coming to this nausea and vomiting, how is this vomiting happening? Or what is causing this vomiting? How are we getting that reflex to vomit? Huh? You don't have to go in great detail, but understand these are the 5 players when it comes to vomiting. Okay, one is area prostrema or the CT, chemotherapy trigger zone. Then we have some receptors in GIT which causes nausea and vomiting. We have some receptors in the vestibular nucleus which causes nausea and vomiting, and some receptors in the cerebral cortex. Okay, when all these 4 things get stimulated with the receptors, they directly send some message to the vomiting center. Okay, now from that vomiting center, when it gets stimulated, the person has the reflex to vomit. Any doubts? Just understand these 4 people, they come together and stimulate the vomiting center. Okay, and then the patient starts vomiting. You'll understand it better now in the video which we are going to show you. Video. Has given you some idea regarding how vomiting is happening and what is the importance of receptors. And you saw there are so the importance of these receptors and how this is going to help you by knowing the receptors, the different antiemetic which is going to act in different receptors. So we saw some receptors at the stomach, area prostrema or the CT set. We had some receptors at the cerebral cortex. We had some receptors at the vestibular nuclei, and all these things come and stimulate the vomiting center, and thereby the emesis or vomiting happens. Okay, so you just have to know that there are certain receptors like cholinergic receptors, 5-HT3 receptors. So we are trying to block these receptors and prevent the person from vomiting. So these are the different drugs which is available, and you are having your anticholinergics like hyoscine and dicyclomine. Hyoscine or your buscopan, it is a very wonderful drug. Especially it is very commonly used in our setting. Metoclopramide, as you know, it is a prokinetic. What does prokinetic means? It helps in forward movement of the gut. Okay, so it helps in the forward movement of gut. What happens if the patient is having intestinal obstruction and you're giving this prokinetic? What will happen? Prokinetic. Metoclopramide means the common perinom that you're using is metoclopramide. And you are giving him, he's having intestinal obstruction and you're giving him metoclopramide. What will happen? Just think, his intestinal
Antagonist will start.
No, sister, my question was, the patient is identified to have intestinal obstruction and he is having vomiting, and you're giving him perinom or the metoclopramide, which is a prokinetic drug. Okay, now if you are giving metoclopramide or prokinetic drug in this intestinal obstruction patient, what will happen? Bowel movement stops. That is what Mamta is saying. What else can happen? His pain can aggravate. Isn't it? There is an obstruction and the bowel is, you are giving metoclopramide and your pain is, the intestine is having the forward movement. And here you're having the obstruction and this movement is coming and pressing. Or that forward movement, what happens? The patient will have severe pain. So that is where the importance of identifying the cause and choosing the correct antiemetic. So in such situations, you are not supposed to give metoclopramide. You can use other antiemetics like ondansetron, or 5-HT3 agonist. Ondansetron is 5-HT3 agonist, and also you can use hyoscine butyl bromide or hyoscine. It is an anticholinergic. What it does is it is an anti-secretory. It will reduce the content in the vomitus and also it helps in controlling the pain as well. Okay. So whenever you're choosing an antiemetic, make sure it is not causing any harm for him, or identify the cause and only then give the antiemetic. Okay, so buscopan is a common drug which we can use in decreasing the secretions or decreasing the volume of vomitus, which is very commonly used. And next you have chlorpromazine, which is a D2 blocker. And you have prokinetics like metoclopramide, domperidone, itropide and noxapride and all that. But domperidone and metoclopramide is very commonly used. The only problem with that, it is a prokinetic drug. But if the patient is not having any intestinal obstruction or any other problems, it helps in forward movement, and also you can give it in patients with constipation. In relieving that, because of this forward propulsive action, it will help the patient in passing stools as well. So after you start the antiemetic, make sure you're observing him properly. Okay. So and then if there is a need, okay, anyhow you started metoclopramide. In one situation, you started metoclopramide, and after 24 hours when you're seeing him, he's having pain. Then what you have to do? You should keep this thing in mind. Maybe this thing has caused some intestinal obstruction. I have to stop this medicine. Maybe you can tell your doctors also, see, this has happened. Maybe you are the one who is calling the doctors and saying no. So you have to observe these kind of things, if it is developing or not. Then other antiemetics which you can try is H1 antihistamic thing like diphenhydramine and all that. Then 5-HT3 antagonists like ondansetron, grandicetron and all that. This is other set of drugs which blocks the 5-HT3 receptors. Okay, then you have adjuvant antiemetics. Here adjuvant is also very important because dexamethasone, it is a steroid. It is not an antiemetic. Still, we prefer to use dexamethasone. Why? In the causes we discussed regarding liver mets or gastrointestinal dilatation, which can be caused by some tumors or mets. What happens when we give dexamethasone? This stretching or the edema, this dexamethasone will try to bring down the edema. Thereby, what happens? The patient will have relief in nausea and vomiting. So even though dexamethasone is not an antiemetic, but it is an adjuvant antiemetic, can be given. We prefer giving dexamethasone instead of some other steroids. Why? Because it has a longer duration of action. It can be given as single dose. It helps the patient in decreasing nausea and vomiting. Usually we give it antiemetic dose is around 4 to 8 milligrams. We can give it as a single dose in the morning, initial phase of the day. Why? Because if you give it in the later half of the day, it disturbs the patient's sleep. Okay, so we prefer to give, if you're giving 4 milligrams, you prefer to give it on the morning time. Okay, especially if the patient is on some chemotherapy, we give this as the previous day morning, we advise them to take it. And benzodiazepines are commonly used, especially in case of anticipatory vomiting. The previous day, the patient is having severe anxiety that he is not able to sleep, he is having continuous vomiting. Then we prefer to give benzodiazepines. Especially we use lorazepam and all that. It can be given as sublingually, 1 to 2 milligrams can be given as orally also, or sublingually you can keep that tablet in the mouth. Then you have some other medicines as well, but this is a common thing which we use. Okay, so whenever you choose an anti-emetic, know what is that anti-emetic, whether it can be given in that particular condition or it should not be given, and make sure you have you observe the patient for any symptoms which is developing after you start an anti-emetic. Now you have given all these medicines. Yeah, you have given all these different types of medicines, still is having vomiting, and that condition is called refractory vomiting. So in such conditions, what we do is we can try antipsychotics like haloperidol. Haloperidol, you say it's an antipsychotic, but in palliative care practice, we used to give haloperidol because it helps in bringing down this nausea and vomiting, especially in case of refractory vomiting. Okay, usually the dose is 0.5 to 2 milligrams can be given, but over 24 hours, it can go up to 5 or 5 to 20 milligrams also. We can, maybe we may have to give if it is in a severe case. But usually on the smaller doses, it helps the patient. And then there are other drugs like olanzapine also, which is also very common. As you can see here, it blocks or it acts on multiple receptors. Like you can see D1, D2, D3, serotonin receptors, cholinergic receptors. At multiple levels, there is action. That is why we prefer olanzapine also can be used in refractory vomiting. Levopromazine is also another drug which can be used in case of refractory nausea and vomiting. And as I said earlier, corticosteroids can be used. Usually, it is an anti-emetic dose is usually 4 to 8 milligrams per day. Can be used up to 16 milligrams in case of intestinal obstruction, and also some intracranial lesions or intracranial when pressure is increased due to some tumor. Then we can use up to 16 milligrams. But for an anti-emetic dose, it is usually 4 to 8 milligrams. Okay, then octreotide is also an anti-secretory agent. It helps in bringing down the volume of the vomitus. But only problem with that is it is a bit expensive when compared to buscopan or hyoscine butyl bromide. But it is also a very good drug used for treating nausea and vomiting. Okay. Again, hyoscine butyl bromide, it is an anti-muscarinic in action, and it helps in decreasing the secretions. It is also very commonly used. Cannabinoids and benzodiazepines are also commonly used. Okay, now just you should be aware of the different antiemetics that you are giving and how it is going to act on the person, different receptors, and how this medicine is going to act on the receptors. All these things should be kept in mind. Okay, now coming to the route of antiemetic. As per the patient's condition and preference, we have to choose the antiemetic. For some people, it might be just nausea and mild vomiting. Then you can try giving oral antiemetics. If it is not helping him, definitely we have to switch to IV antiemetics. Okay, or refractory vomiting means there is only option for IV or subQ. Oral route is usually the best and the easiest way. If vomiting is severe, then we will have to choose IV, subQ, or continuous subcutaneous infusions. There are suppositories and sublingual route, which is also available. Transdermal patches are also available for administering antiemetics. Now, these are the some of the guidelines which you should always keep in mind regarding the management of nausea and vomiting. Okay. Now, document the likely causes. Okay, what is the cause for nausea and vomiting? First and foremost, you have to know what is causing it. Then treat the potentially reversible causes and exacerbating factors. Some drugs. Is it constipation which is leading to nausea and vomiting? Is there severe pain or infection or any other? Is it associated with some cough? So these things should be always looked for. Review the dose after every 24 hours. Once you have started an antiemetic, it is not like, okay, why we are going. No, you have to always check. Is he doing well after starting this? And if still it is persisting after 24 hours, then again you have to check for the cause. Was it the first cause that I thought of? Or maybe some other thing has added on to this or not. Okay, so review the cause, and maybe if it is not just one antiemetic that is going to help, you may have to add some adjuvant antiemetics as well. If the patient is started on Perinome, maybe he'll need a dose of corticosteroid also to control his nausea and vomiting. Okay, maybe some amount of benzodiazepine will also help him. So this is, how do we decide all this? It is done by practice. You understand the patient, talk with him, try to explore the cause, and once you know the cause, definitely you can add on all this. If no parenteral route, if on parenteral route, consider converting to oral after 72 hours of good control to oral regimen. That means like if you are giving him IV antiemetic, maybe after 72 hours, you can switch him to oral route. Okay, and then try if it is helping him. If again, once you started him on oral route, he's having vomiting, then you may have to switch him back on IV. Now, these are the doses which you need to have a brief idea of, especially haloperidol. It is not commonly used as an antiemetic in other setting, but in palliative care setting, we commonly use it. Haloperidol, the starting dose can be from 1.5 to, it can go up to 20 milligrams per day as per orally or up to subcutaneous or as subcutaneous route. Metoclopramide also 10 to 30 milligrams, we can give it every 2 to 4 hourly. Same here as per oral, subcutaneous or IV routes. Domperidone 10 to 30 milligrams from 4 to 8 hourly you can give. Ondansetron, diphenhydramine that is commonly given before chemotherapy. Octreotide 50 to 100 mcg every 4 to 8 hourly can be given. Dexamethasone, as I said earlier, the dose is usually from 4 to 8 milligrams given 8 hourly. It can also be given as orally, IV or subcu. Only thing that you have to keep in mind is dexamethasone should be given in the first half, in the as morning dose. If you give it in the afternoon after the day, I mean, post the day, what happens is it disturbs with its with the patient's sleep. So make sure you're giving it in the morning. So with this, we come to the next half of our session, which is constipation. Before that, if you have any doubts, please feel free to ask. Is it clear? Or did you not understand anything? That is why you're not asking anything.
Only thought vomiting is a complaint, but today class is vomiting is one chapter. So,
So did you have that idea that this was such a
yes,
big topic?
having some ideas. Thank you.
Okay, so I hope this was helpful because you are going to see more patients with this symptom, and it is really distressing for the patient. That is why being on a palliative care setting, definitely this will help you in improving your practice as well. Okay, if you have any questions, make sure you note it down. At the end of the session, we can have that session to discuss all that. Okay, now we'll move on with constipation. What is constipation?
Obstruct of the fecal matter in intestinal obstruction.
Intestinal. Before that, can a person come and say you, I think I'm feeling constipated? Or what is a common thing which person come and say to you on an OP basis?
Not past stool 2 or 3 days.
Okay, yes. This is also one thing which we hear. Not passing stools more than 2 to 3 days. That is a typical definition that you get. Okay, anyways, today what we are going to learn is what is constipation, why is it important, and what causes constipation, and how do we assess it. Constipation is usually a very common symptom which the patient comes and says to you. Okay, so it is a subjective feeling. It is different from one person to the other. For some people, it is normal to pass motion every third day. That may be their usual pattern. Like I'll say, like usually my bowel pattern is once in 3 days. That is my normal. For some people, it will be like every day he has to pass stools. That is his normal. So whenever the person says he is constipated, ask what is his normal pattern. How is it different from their normal when a person says that he is constipated? Constipation means it is difficult or painful defecation and is associated with infrequent bowel evacuation and has hard stools. He will be not satisfied with his bowel pattern, unsatisfactory bowel patterns. Okay, so that the days that we say, usually in most of the textbooks that you see, will say they will be saying like not passing stool more than 3 days. So when it comes to palliative care setting, it can be different. Ask what is their normal pattern, and if he says he's constipated, maybe he's saying 1 week constipation as constipation. Usually he passes stools every 3 days, but since 1 week he's not passing stool, that is constipation for him. If one person is not passing motion on one particular day, he feels he's constipated. So it is a subjective feeling. Okay, more than 45% of people in palliative care setting, when you see him first time itself, they will be constipated. Okay, it is a very important feature which should be asked for, but quite often missed. So hereafter, I want every one of you to keep in mind, whenever you're seeing a patient, make sure you ask him how is his bowel pattern. Even constipation can be a cause for nausea and vomiting. We saw opioids, no? Opioids can cause constipation as well as nausea and vomiting. So ask regarding such things. Now, what are the common symptoms that the patient will be saying? He has that feeling of incomplete evacuation. That bowel movement is not satisfactory. There will be bloated feeling. There is associated nausea and vomiting sometimes. There can be abdominal cramps or pain, abdominal pain. Finally, it can lead to bowel obstruction. Some can present with overflow diarrhea and urinary retention. Have anybody heard of overflow diarrhea or spurious diarrhea? Jesse Joseph says, today it is helpful but tough. It is a little bit of tough from, I understand it is quite different from your day-to-day practice. As I said earlier, for each symptom, the cause is different. We may feel it as a simple nausea and vomiting or even constipation. You give lactulose, it is enough. But here again, choosing the correct laxative is also tricky. So we should know what is causing it. If we give that medicine, how is the patient going to respond back? All these things should be kept in mind. Okay. So yeah, overflow diarrhea. Have anybody heard of that? Some of you might be thinking, I started the topic saying constipation, now I am talking about diarrhea. Any idea?
Fecal matters, overflow leads to diarrhea.
Overflow, how is that overflow happening?
So obstruction leads.
Okay. Anyone, any other answers? After constipation?
Intestine cannot hold, maybe. Pull, maybe.
So in this picture, Everyone, I hope everyone can see this. So in this picture, you can see the anal opening, you can see the rectum, and you can see the fecal mass. Is it clear? Are you able to understand? Give me a thumbs up in chat. So here, after a period of constipation, you can see the patient presenting with overflow diarrhea. That means the patient will have small amount of fecal matter coming on and off. Like whenever we ask the patient or the caregiver may be saying, it's okay, we don't have any problem with what to say, like there is bowel is being opened regularly, in between small amount of motion is passed every day. See, but he may not be having complete satisfactory bowel movement. Here what happens is this fecal matter or maybe fecalith formation can occur. The hard feces might have been formed there, and this will prevent from the newly formed stools will be coming from this side. And what happens, that fluid sweeps down through this area and comes out mixed with some amount of fecal matter. So after a period of constipation, some amount of fecal matter, soft stool that is being formed higher up will seep down through these sides of the anal opening, and that fecal matter will come down, which is seen as which we say it as spurious diarrhea or overflow diarrhea. So here what we have to do is we have to do a rectal examination and try to remove this fecalith. Sometimes it is possible, sometimes it is not possible, but manual evacuation, whenever possible, we have to remove that. Only then the motion which is formed in the higher up side will come down. Okay, so this is spurious diarrhea or overflow diarrhea. So after this class, make sure you understand, even if a patient is saying I'm passing stool, ask him whether it is satisfactory. Or sometimes the patient may say I'm having diarrhea. See, on and off, continuously motion is going. Give me some medicine to stop this. This is how the patient may be presenting to you. But ask him when he had the last satisfactory bowel movement. He might say a clear history that he was constipated and after that this diarrhea started. This is the typical history that you get. So, spurious diarrhea is after a period of constipation, the patient will present to you with diarrhea. It is not diarrhea, it is the soft stool which is seeping down through the sides of the fecalith and coming out, which the patient thinks as diarrhea. Okay. Now another symptom which the patient can present with is urinary retention. So some patient, they'll be on this Foley's catheter, CBD, continuous bladder drain. When we go for home care, or even they'll call us and say, see doctor, this catheter is blocked, you have to come and change this Foley's catheter for us. So quite often when we go there, what happens is the patient will be severely constipated. There may not be any problem that they complained also. They'll just say this catheter is blocked, please come and change it. So when we go there, this is very commonly seen. So when we go there, what happens is we do a rectal examination and we come to know that he is constipated. Once we relieve his constipation, we give enema. After that, without changing the catheter itself, the urine will start flowing clearly. Okay, so the person can present to you with urinary retention also. Even if the patient is not catheterized, the patient may have urinary retention, can present to you with urinary retention. So always ask for his bowel pattern. So once his bowel pattern is okay, you give him an enema, then you can see that urinary retention is resolved. So these symptoms, what are they? Feeling of incomplete bowel evacuation, that bloated feeling. There can be associated nausea and vomiting. There can be abdominal cramps, bowel obstruction, and the patient can present you with overflow diarrhea or urinary retention. Now, what causes this constipation? Here again, it is important to know the causes Sometimes it can be pharmacology related, like opioids. 90% of the cancer patients will be on opioids, and this in turn can lead to constipation. And some antidepressants, anticholinergics, antiemetics or antacids. Antiemetic that causes constipation is ondansetron. It causes gastrostasis. That if prokinetic is it causes the forward if what to say. Yeah, prokinetic causes the forward propulsion of the gastric intestine, whereas ondansetron it causes gastric stasis. It stops that forward propulsion and thereby preventing this vomiting. So that kind of antiemetics can cause constipation. Some antacids, somatostatin analogs can also cause constipation. Some metabolic factors like dehydration, hypercalcemia, hypokalemia, and diet which is very poor in fiber and fluids, and the patient may not be having good appetite. All this can also cause constipation. Environmental factors, this is also very important, because if the patient is hospitalized and he has to use a common toilet, he may not be comfortable using that. So environmental factors can also be a thing which causes constipation. And inability to attend to call. The patient is very fragile. Means he's not able to move out of his bed alone. He needs the help of somebody. So in such situations also, he is not able to answer, inability to attend the call leads to constipation. Neurological factors, something like malignant spinal cord compression or some nerve infiltration can cause constipation. Then any tumors or RT induced, these factors can cause constipation. And if the patient is having or diagnosed to have depression or immobility, inactivity, all this can cause constipation. So these causes should be kept in mind. So why are we concerned if the patient is having constipation? Because in advanced diseases, it can cause colicky abdominal pain, anorexia. Yeah, it can cause colicky abdominal pain, anorexia, nausea and vomiting, urinary retention, anxiety, confusion and delirium in elderly. Most commonly, you can see elderly patient having delirium, and the cause for that delirium will be constipation. It's quite missed out. And also, sometimes the patient can present with urinary tract infection related to this constipation as well. And as I said earlier, morphine, it causes constipation. It decreases the propulsive activity. And when the propulsive action decreases, again, the water reabsorption time in the intestine increases, thereby leading to constipation. And it also causes inhibition of the secretomotor neurons, thereby the fluid that is entering the gut decreases, which again leads to constipation. Now, it also has it reduces the sensation of the rectal distension and thereby leading to fecal impaction. So that is why whenever we give morphine, we always give laxatives along with that. I hope morphine class is over, so you might have already learned it. So whenever you write morphine, make sure you write a laxative. The common laxative that we use is bisacodyl and clemantine. We'll come to that. So in assessment, what is the normal pattern for the patient? Frequency and the amount, consistency, is it bloodstained or not? When was the last bowel movement? Is the patient experiencing any abdominal discomfort, cramp, nausea or vomiting? Is there any excessive gas or rectal fullness? Does the patient regularly take laxatives? What medications are the patients on? Is constipation a recent change, or what is the type of diet that the patient is on? All these questions should be asked to your patient. So here again, another common thing which we come across in our practice is the caregiver will be saying he is not taking enough food. Then how will he pass motion? So it's one thing which we commonly see. And the second thing which the patient says is he's having diarrhea, and you're saying you're going to give enema. What is the use? He's already having diarrhea. These two common things are the common issues which we see in our practice. And we have to make the patient as well as the caregiver understand that even if the patient is not having food, there is some amount of metabolic waste that is being generated in the body. So it is important to give laxatives regularly. Okay. To understand more about the bowel pattern, make sure you show this type of chart. It is called as Bristol stool chart. Show them to understand their bowel pattern. You can show the picture and ask them to say how is their bowel movement, or is there any of this type of bowel pattern which is having. Now coming to the management, here again, correct the correctable. You have to use laxatives, improve the general condition, symptom control. You have to check on the fiber content of diet, encourage activity. If he is bedbound, at least some amount of activity, whichever is possible. And at least give him some PROM exercises or something like that. If the patient is walkable, encourage him to walk more. Okay. Okay. Here again, you have non-pharmacological measures like daily assessment, improve mobility, access to toilet facility, prompt response to patient call, give him adequate privacy. Okay, diet and fluid intake. Privacy is also very important because in a hospital setting, he is bedbound, but maybe he may have to pass motion in a diaper, which is very difficult for him because he feel very awkward that should be cleaned by some other people. So it is making him consciously he is not passing motion. Okay, so privacy is also another thing which we have to consider and facilitate him to whatever he is comfortable. You can give him a bedpan or maybe a commode chair, or use the wheelchair and take him to a toilet facility. Such things should be encouraged. Okay, then diet and fluid intake, all those things should be kept in mind. Attention to other symptoms. Is there any thing which you are missing out, or is there laxatives properly given? All those things should be kept in mind. And now we have to see the rectal examination. I hope most of you might have done your rectal examination. When we do a rectal examination, if the rectum is empty and collapsed, what does that indicate? It indicates a normal functioning bowel. Okay. Now, if the rectum is empty, when we do a rectal examination, we feel that it is empty, but it is dilated. What does that mean? Usually, it should be collapsed. That is the normal anal stone, that collapsed rectum. If it is dilated, it indicates that feces is higher up, and it indicates feces is higher up. Maybe you will have to give an enema, or maybe there is enough room for your fingers to move around. That means it indicates gross constipation. Okay, here again you will have to give high-up enema. High-up enema means here you put a suction catheter and then you give your phosphate enema. Usually what we do is we put a suction catheter and we give 2 phosphate enemas together. Okay, this has to be repeated maybe on the second day also until the patient is having a good satisfactory bowel pattern. And if when you do a correct examination, you find to have feces in the rectum, it is soft feces, then you can manually remove it. And even if it's hard, if it is possible, remove it and then keep a suppository as required. Determine, if you get the feces, determine the consistency and manage accordingly. And if you do a PR, if you get some irregular, hard, immobile, then that means it could be some kind of tumor or mass. Then you have to refer for higher or further evaluation. Okay, so these are the common findings that you get while doing a rectal examination. So whenever we start giving him, whenever the patient is started on morphine, we know the common side effect of morphine is constipation. Make sure a laxative is given along with morphine. Okay, so always prevention is better. So these are the common laxatives that is seen. You have bulk forming laxatives, but usually we don't prefer bulk forming laxatives. Good. Psychiatric helps in nausea and vomiting. Okay. Okay, last we'll take that. So yeah, laxatives, bulk forming laxatives, it increases the stool amount, but it is difficult for the patient to pass. Usually we don't prefer any palliative care setting because the patient may have dehydration also when we are giving bulk forming laxatives. We can give stool softeners. Here again, liquid paraffin, decosine sodium, decosate sodium. These are the common stool softeners. Then osmotic stool laxatives are lactulose, magnesium salts, and magnesium hydroxide suspension. Stimulant laxatives, which is very commonly used in our setting, especially bisacodyl. And in large bowel setting, we have Senna, but in our which we use is bisacodyl. These are stimulant laxatives. We can't give stimulant laxatives alone. Along with that, a stool softener should also be given. And other prokinetics, like as I said earlier, metoclopramide is a very good prokinetic. It helps in forward movement of the intestine. So bulk forming, what happens? It increases the fecal mass, thereby peristalsis. Here the stool that is formed is bulkier and softer, but it is unsuitable for elderly and debilitated patients as they need to drink extra fluid and not normally used in palliative care setting. We have osmotic laxatives like lactulose, but it also has a common problem, that is dehydration, and so for some people it can cause cramping or nausea sensation. Which we prefer to use is primarphin or liquid paraffin. It is not used alone, it should be given with a stimulant laxative. Stimulant laxative, as I said earlier, bisacodyl is a common laxative which is being used. So whenever we write the prescription, bisacodyl can be given as a single dose at night, 10 milligrams, or if you're getting 5 milligrams tablet, 2 tablet at night. First you give it as excess dose, then you can, if the patient is not passing still, you can increase the dose as DD, morning and evening. Still it is not helping him, then we can give it as TDS along with the stool softener. When then again you have to see, do the rectal measures, do a rectal examination. If manual removal is possible, do that. You can keep a suppository if required, or give a high or low enema. Usually we prefer high up enema in case of severe balloony rectum and all that. It indicates severe constipation. We prefer a high up enema. So spurious diarrhea or overflow diarrhea, which we already discussed. It is sudden onset of diarrhea after a period of constipation. Rectal examination and digital evacuation is commonly done, and also regularizing laxatives is very important. Constipation, it is not a disease, it is a symptom. So if no laxatives work, it means that you are not giving enough. Some people may come to us and say, yes, I'm taking this laxative, still bowel is not being opened. Or some people, what happens is they may say, if I take this, stool comes, the purging of stool happens, which is very difficult for me. I feel so dehydrated, I don't want to take that. So what happens is, you have to make them understand, since you were not taking it regularly, this purging of stool happened. Without this, it is going to cause a lot of problems for you. Make them understand the plus and minus of taking this. Okay. And always make sure you are giving a stool softener and a stimulant laxative together. So here again, we come to the case discussion. Like on the initial setting which we discussed, a 55-year-old frail lady, she is diagnosed to have gastric carcinoma. She was on chemotherapy and urinary tract infection was there. And she was admitted for treating her vomiting and abdominal colic. And she was on IV antibiotics. She had small, frequent, incomplete bowel movements for the past 4 days. And she was started on laxatives today. She is accompanied by her younger daughter. So what do you think are the issues here? Now I want you, every one of you, to answer these questions. Now you have had all the information required to answer this question. Yes, sisters. Constipation and urine infection. Okay. Now, how would you like to investigate? How will you investigate urinary infection? You can unmute and say.
We can have urinary culture.
Okay. You can do a urine routine, do a urinary culture, and then start antibiotic. Now, how will you investigate for constipation?
Like, first of all, we'll assess the patient for how long her bowel is not open, and plus we will do rectal examination.
Yeah. Yes. Is there anything else that you can do as a part of investigation? You can do erect X-ray. In the erect X-ray, you can see gas formation or the fecal matter in the X-ray, whereby that is also an investigation modality which can be used. Now, coming to the in the history, you can see she is accompanied by her younger daughter. Does that give you any hint? So there are some environmental factors or some other factors, like she is not having the help of any elderly person to assist her to go to the toilet. So such things should also be considered. Okay, so there are medications that you can give, whatever it is you can give, but there are some non-pharmacological measures also that you should be keeping in mind while you're treating this person. Now coming to the management, as I said earlier, we have a lot of antiemetics. According to the condition, we can give her and make sure she is we can manage her by doing a rectal examination. If we want, we can give enema if required in managing this condition. Yeah, thank you. So one person, she had asked regarding the antipsychotics, how do we use that? So antipsychotics, so haloperidol is a common antipsychotic that we use as antiemetic. It is very commonly used in our practice, especially in case of refractory vomiting. You can use corticosteroids also. Commonly, what we use is haloperidol. Olanzapine also is also used in different centers in case of refractory vomiting. Yeah, is there any other doubts? Yes.
Thank you, Dr. Sangeetha, for that wonderful presentation. I think we don't have enough time for a case presentation as we are running out of time. Thank you so much, ma'am, for being here with us. Thank you for your all for joining us today. And the feedback link will be shared in your WhatsApp group. Thank you. I'm sorry that we couldn't present the patient story today. We will be presenting it on the next session. Thank you all. Bye-bye.
Thank you.